Hi, my name is Dr. Robert Kaufman, and we're about to go beyond the terminus. Today's topic is continuation of our discussion of emergency treatment and treatment planning. This is the second part of a three-part series. In this case, symptoms are not improving or moving from cold sensitivity to heat sensitivity. Thermal tests produce unacceptable levels of thermal sensitivity for the patient or protracted symptoms. No percussion sensitivity is present, and the periapical radiographic findings, again, are within normal limits. Pulp is still vital, but it's likely heading toward an irreversible pulpitis stage. In the cases of thermal sensitivity and toothache without periapical involvement, it's often enough to perform a pulpotomy as an emergency procedure. Ideally, we'd like to remove the entire pulp with something like a broach, but in the absence of any periapically related symptoms, a pulpotomy, similar to that of a pedopulpotomy in posterior teeth, can provide sufficient relief from thermal symptoms until endodontic treatment can be scheduled. In anterior teeth, we usually try to do the entire pulpectomy either with a broach or with hand instruments or rotary instruments. Patients can be given ibuprofen or Tylenol to manage any post-op symptoms they may have. Antibiotics are not indicated and should not be prescribed. Antibiotics used just in case have no basis for prescription. The literature is clear. In the case of irreversible pulpitis with thermal sensitivity that's prolonged or delayed, especially to heat, you need to confirm the symptoms with the patient's claimed provoking symptoms. The patients frequently have been unable to sleep, and over-the-counter analgesics frequently have no effect or minimal effect. Patients will say that there's a history of thermal sensitivity, but may present with no responses to temperature tests at all. The tooth may start to show signs of percussive sensitivity, likely indicating that the irreversible pulpitis is in the end stage and it's moving toward periodontitis. You can usually figure out which tooth it is because the tooth will now be slightly percussion or chewing sensitive. Associated periapical radiolucent findings are sometimes, but not always present. Because of the fluidity of the pulpitic process, pulps can go non-vital overnight. These patients are acutely involved, sometimes to the point of tears. What's our treatment? In the case of irreversible pulpitis, removal of the decay, defective restorations, cracked tooth structure, and pulp extirpation is usually enough to get the patient comfortable. Take the pulp out and get as much of you can out at this stage. Our first obligation is to get the acute symptoms under control. And the tooth requires a pulpectomy because a pulpotomy is insufficient to deal with the breakdown products of the canal system that are leaking into the periapex. Good anesthesia is important not only for patient comfort, but to lessen stress to the operator. Don't forget to confirm anesthesia in thermally sensitive or percussive sensitive teeth before you start. Cursory cleaning to within a few millimeters of the apex is indicated through instrumentation to the apex, confirmed by electronic apex locator, is preferred. The canals are irrigated with sodium hypochlorite and medicated with calcium hydroxide and closed with a temporary filling. The occlusion is relieved and the patient is scheduled for endo treatment. Again, in the absence of gross swelling, no antibiotic medication is indicated. There is no justification for a just-in-case prescription of antibiotics regardless of the previous practices or the patient demands. Once you get the patient comfortable and the tooth is closed, you need to discuss any additional procedures with the patient, such as the need for crown lengthening or whether you wish to incorporate this into bridge as an abutment tooth, and examine the occlusion to see if this tooth is a good candidate for rehabilitation. In the case of the non-vital tooth, it is periapical involvement that determines how we handle the case on an emergency. The tooth is acutely percussive sensitive without gross periapical swelling, removal of the remaining pulp and medication of the canal with calcium hydroxide and relief of the occlusion is usually sufficient to tide the patient over until the next treatment appointment. Remember, no antibiotics in the case of irreversible pulpitis. Remember, when we do the right thing, not only do we get better, but patients get better too. Thank you for joining me on this trip, and I hope to see you again when we go beyond the terminus.